let's move on to, to the next stage where, we have a patient with, hormone-sensitive metastatic prostate cancer, and now they are going to start the treatment. And, we have a great data with an ARASENS trial that looked at the triplet combination of ADT chemotherapy and adding darolutamide to that base of ADT and chemotherapy. And then really exciting time to have this type of data where triplet therapy has shown significant improvement in survival and in multiple other endpoints. So I think based on that ARASENS trial, at least in my practice, we have started using the triplet or what we call an intensified therapy for some of these patients. So wanted to ask you all as far as how do you approach that? And obviously, you have to get the medical oncologist on board to do the chemotherapy portion of that. As I understand, most of the urology practices doesn't have a way to do the chemotherapy. So wanted to see your experience and how do you all collaborate that. Dr. Perkel.
Yeah, I think the communication aspect, when I meet with that patient and I feel that they're going to benefit from triple therapy, I discuss that up front, not just I'm sending you to the medical oncologist, I'm sending you to the medical oncologist and this is what they're going to talk to you about, and I'm going to give you this information, and then I'll kind of give them a little bit, well, they're the captain of that ship, so, they may end up, but usually we're all reading the same guidelines, we're all reading the same data. That's usually what they're going to get in that setting. 9 times out of 10, I haven't had one lately that hasn't. And then, I kind of give them a little bit of a pep talk that, the patients I've had that have all gotten through therapy. They do very well. I try to I try to give it more in a layman's term that the blockade of the testosterone weakens the cancer so the chemotherapy can kill it better, and it works better together with the chemo rather than just the shot and the pill by themselves. And, people sort of, they get, hope that they're getting a good treatment, 30% survival advantage, with the triple therapy, or 32%. That way at least they feel, because, so many times patients come to our office and you say, why are you here? And they say, because my doctor sent me. I don't know that they're going to be able to repeat that whole story, but they know, maybe they remember they're going to talk about 3 things. And if they get with that, and then just depending on the patient and the timing and, the prior auth and if they need it or not, I might start the ADT injection, at the initial, at that initial consult or shortly thereafter. Fortunately, there's not a big delay with us. Our medical oncologists get them in 1 or 2 weeks. So whether, unless they're having real bad symptoms, I don't know that particularly makes a difference. But, and they're very collaborative. If we give the ADT, sometimes we'll continue. If it's somebody who's, a lot of times I'll just transition it and they'll give the second shot. And so we do that kind of on a case-by-case basis. So there might be some variability there. At one point I would start the oral, but with the specialty pharmacy, and our medical oncologists have their own specialty pharmacy, it's just easier for them. By the time I fill out the paperwork, they've already given the drug. So I just let them handle that, and it takes some of the workload off my medical assistant having to fill those out too, which is nice.
Good. So it looks like you really have a good, collaboration with your medical oncologist, and that's very important. And as we said, so Dr. Laungani, other aspect, and I think you kind of touched on this before about the quality of life. These patients are going to be on a treatment for a long time, years and years. So if you can just shed light on that as far as how do you incorporate that and give some more details as far as how do you handle that?
I kind of express to every one of my patients that this is a marathon, not a sprint, and you always get a medal for finishing. You don't have to finish in the fastest time, but as long as you finish, that's all that really matters. And again, to what Dr. Perkel said is really just, we're not really bouncing the patient back and forth between medical oncology and urology, but we're kind of involved in a shared care aspect of their treatment. And I think expressing that to them, reassuring them that this is not the end point, but this is part of the journey and part of the treatment, which we believe gives you the best chance of overall survival, particularly in situations where we're administering triple therapy, kind of really reassures them. Because again, to Dr. Bear's point, they look at us as the quarterback. We have to run the play. We have to figure out what's best for the team. And in this case, the team would be the treatment team. And in that case, we say, okay, we think at this stage, you're best served by going to see the medical oncologist. And guess what? I'm just going to call him on the phone as soon as I step out of your room and say, hey, this gentleman's going to be calling your office. Let's get him set up for what we're doing. And then we have the ability to, at that point, talk about Lupron or Govix, any of the other novel oral therapies, and then go from there. But if you're going to take on advanced prostate cancer, yes, you have to be prepared to have your medical oncologist on speed dial and say, this is what's going on, when can you get him in, and it should be that easy.